One of the deadliest effects of COVID-19 is that it ravages the lungs, disrupting the flow of oxygen to the body.
There is greater demand and need for ventilators than we actually have physical machines to treat people with.
And once people go on these ventilators, they're on them sometimes for 2 weeks at a time, sometimes longer, which is much more than you often see in ICUs. So you have a big increase in demand all of a sudden and no real way to up supply that quickly.
Producing new ventilators from scratch is an expensive and slow process. So scientists at the Nikalson lab looked into previous research on dual ventilation.
While mechanical ventilators have been around for a long time, it's actually only fairly recently people have started to talk, at least in academic literature, about sharing them over multiple patients. And I think that's because we're mostly not in a resource limited setting most of the time.
The earliest attempts essentially just take the outflow from the ventilator and split it into two, and then figure out the vent settings in a way that you can sustain 2 patients on it.
That method of ventilator splitting, where you just sort of do a simple splitter that divides air, you can't treat multiple patients differently. Every patient is going to see the same airway pressures, no matter what airway pressures they need.
This led the team to focus their design on regulating air pressure to individualize care for each patient.
In a pressure-driven ventilation, no matter what the patient's lung compliance is, they're going to see the same pressure, and that means they get the volume that is appropriate for them in that situation, and they are not at risk of damaging their tissues due to having too much volume be pushed in or out.
In COVID, you have patients with lungs in all sorts of stages of injury, and some you need very different pressures for than others, and those pressures can change over time.
These patients are hospitalized for a long time, and you really want to make sure that the ventilation that you're doing is not causing added damage to the lung.
And what we're able to do is by using some adjustable pressure regulated valves that are actually found in, normally in the hospital and in ICUs. We just put them within the circuit in certain places. And this lets us independently decrease the pressure used to inflate the lungs and increase the pressure used to keep the lungs open. And adjusting the settings for one patient has no effect on the settings on the other patient.
The flexibility of this pressure-controlled system is what makes it such a powerful tool in the fight against COVID-19.
It's especially important when we're learning new things about the disease every day, and when it seems like on Monday, 2 patients will be great together and they'll both have the same course. If you learn something on Wednesday where you want to change one patient's treatment, you don't want to find yourself in a situation where one patient holding up another patient's recovery.
And our hopes for this is that we can get this essentially out to hospitals rapidly, hopefully within the coming month or even maybe within the coming weeks for those hospitals that need it the most. And that it can come as like a fully packaged circuit that works, that we know works, that passes all of the testing criteria, comes with instruction manuals, and is hopefully pretty easy for clinicians to use.